Good afternoon. I would like to thank the UPPGH Division of Hematology for the opportunity to present this lecture. I am Dr. Camille Ariadne Sitanchanco, and for this afternoon, let us discuss how we approach difficult cross-matches. The following are the objectives of the lecture. What is pre-transfusion testing, and why is it needed? Pre-transfusion testing includes all activities from when the blood product is ordered by the physician to the final step when the blood product can be dispensed from the laboratory to the patient's bedside. When the blood service provider receives requests for blood products, a series of tests will be activated that aims to provide blood components that will provide maximum benefit while minimizing risk and potential harm to the patient, such as preventing immune-mediated and hemolytic transfusion reactions. These tests include blood typing of the recipient, antibody screening, and cross-matching. This activity emphasizes the importance of positive patient identification, compatibility testing, and appropriate product labeling to ensure that the right blood is given to the right patient at the right dose, hence ensuring appropriate, safe, and compatible blood units. The first step in pre-transfusion testing is the preparation of the test requisition. Requisition must include the patient's information, including full first and last name, unique identification number, and requested tests. Date, time, and dose of intended transfusion should be provided if available, along with any special requirements and clinical indication. Next step would be verifying patient identification. It is essential that hospitals and outpatient areas collecting samples for pre-transfusion testing have a specific policy and procedure for unequivocal patient identification and appropriate labeling of pre-transfusion blood samples. Patient identification must be verified at the time of sample collection. Next would be collection of sample according to hospital or clinic policy. Samples must be labeled in the presence of the patient at the time of collection with the patient's full name and a unique hospital identification number. Also document date and time of sample collection and phlebotomist's name. The patient's blood typing or ABO grouping is performed by ascertaining concordance with both cell typing or forward grouping and serum testing or reverse typing. RHD typing involves testing the patient's red blood cells for the presence of the RHD antigen with the anti-D sera. RHD negative patients may develop antibodies to the RHD antigen if exposed to RHD positive red blood cell. It is therefore preferable to provide Rh-negative blood components to any Rhd-negative individual. Forward typing is performed by mixing the recipient's erythrocytes with commercially available anti-A and anti-B sera and observing for agglutination as seen in this figure, which shows the agglutination patterns for the different blood types. The reverse type is performed using the recipient serum and commercially available group A and B erythrocytes. Results of the forward grouping must agree with the reverse grouping before the patient's blood type or ABO type can be considered valid. Presented in this table is the agglutination patterns of the forward and reverse types and the compatible erythrocytes for transfusion for faster reference. Antibody screening should be performed on all patients who may require transfusion support. The recipient serum is added to a reference panel of commercially available erythrocytes with a known pattern of antigen expression in order to detect antibodies in patient plasma or serum that might react with antigens on transfused RBCs and cause clinically significant hemolysis. The antibody screen is performed by incubating the patient plasma or serum at 37 degrees centigrade with a 2 or 3 donor red cell panel of well-characterized blood group O reagent RBCs expressing combinations of commonly encountered clinically significant RBC antigens. Antibody screening can be performed manually or on an automated system in liquid or solid phase. The US FDA requires that Group O reagent red blood cells used in the detection or identification of unexpected antibodies shall include at least the following common antigens in each lot of the product, specifically Rh, Kel, Duffy, KID, Lewis, P, and MNS blood group systems. Most clinically significant antibodies are usually IgG since it typically reacts at or near body temperature at around 37 degrees centigrade and are more likely to damage incompatible transfused red blood cells than antibodies that react best at lower temperatures. Clinically significant antibodies are associated with hemolytic transfusion reactions. IgM antibodies are generally considered to be less significant than IgG because they are reactive at room temperature but not body temperature, and therefore rarely cause hemolysis in vivo. If antibody screening detects one or more antibodies in the patient's plasma, further testing is performed to identify the antibody or antibodies via antibody identification. The table presented in this slide gives a brief overview of the common blood groups detected in screening and whether they are clinically significant or not. Presented here are the steps for performing the tube antibody screen test. The patient's serum or plasma is mixed with RBCs that have known antigen content. Antibodies have optimum temperatures for reactivity. Reaction readings can be made at different phases: after the immediate spin, after incubation at 37 degrees centigrade, and after the addition of anti-human globulin or AHG and centrifugation. Reactivity in a certain phase will help determine whether the antibody is cold reacting or IgM or warm reacting or IgG. It will also help to distinguish between antibodies that are clinically significant and not significant. In the immediate spin phase, antibodies reacting in this phase tend to be cold reactive. They are usually IgM class and not clinically significant. In the 37 degrees phase, antibodies that react in this phase include strong IgM or IgG antibodies. After incubation, the tubes are examined for the presence of hemolysis. If complement was bound during incubation, then hemolysis could be seen. In the AHG phase, antibodies reacting in this phase are considered clinically significant. They are usually warm reactive and IgG. Antibodies in the Duffy, KID, and KEL blood group systems react most commonly at the AHG phase of testing. Antibodies in the Lewis, MNS, and P blood group systems are commonly IgM antibodies and react optimally at room temperature and below. Antibodies in the RH system generally react at both 37 degrees centigrade and AHG. Antibody identification is performed when the antibody screening is positive. It involves testing of the patient's plasma with a panel of type O red blood cells with known antigen expression. Antibody identification involves multiple steps designed to exclude and confirm particular antibodies, determine the optimal temperature of antibody reactivity, and identify any autologous reactivity. Extended antigen typing of a patient's red blood cells may also assist in antibody identification by establishing which red blood cell antibodies an individual is likely to develop. The time to complete an antibody identification is highly variable and is dependent on the complexity of the antibody investigation required. Patients found to have clinically significant antibodies should be restricted to an antigen-negative RBCs for all future transfusions, even if the antibodies are not apparent on subsequent routine testing. Red cell phenotyping is performed on recipients' red cells to determine which blood group antigens are present or absent in the red cells, and on donor red cells to provide antigen-negative RBC units. It is used in blood banking in four main settings. For blood donors, in order to determine compatibility for a patient with an alloantibody, and to identify donors with uncommon phenotypes. For patients, in order to determine which antigens the patient lacks in order to prevent future antibody formation, and to confirm that the patient is negative for an antigen to which he has formed an antibody. Next step would be compatibility testing. Compatibility testing, also known as cross-matching, is a method of confirming compatibility between the patient and the donor and is the final step in procuring red cell units available for transfusion. It serves two main purposes. First is to serve as a final check of ABO compatibility between donor red cells and patient's plasma or serum. And second, to detect clinically significant antibodies that may have been missed by the antibody screening test. It can be done by computer matching or with serologic testing, depending on current and historical antibody results. Cross-matching is based on the principle of serological detection of any clinically significant irregular or unexpected antibodies in either donor or recipient's blood. Patient's plasma is mixed with donor cells. The sample is centrifuged at room temperature and examined for hemolysis or macroscopic agglutination either immediately or the immediate spin phase crossmatch, or following incubation with the anti-human globulin or the AHG crossmatch. Hemolysis or agglutination of the donor cells is indicative of an antibody in the recipient serum that is directed against an antigen on the donor cells, hence an incompatible crossmatch. In that case, the donor unit is deemed incompatible for transfusion, and further investigations are undertaken to identify the antibody responsible for the reaction. No agglutination can be interpreted as a compatible crossmatch if the patient has a negative antibody screen. For a patient who has a clinically significant antibody or antibodies, the selected units for crossmatch will be antigen negative. Donor red blood cell units are screened to identify those that lack the antigen or antigens corresponding to the antibody or antibodies identified in the patient. Let us now identify the reasons for an incompatible crossmatch. If agglutination occurs during the immediate spin phase, one of the following situations may have occurred. ABO-incompatible donor RBCs, polyagglutinable donor RBCs, cold-reactive allo or autoantibody in the plasma not detected in antibody detection tests, passively acquired anti-A or anti-B, or an antibody reactive at room temperature or anti-M. When the immediate spin phase is positive for agglutination or hemolysis, further testing is required. The donor unit is deemed incompatible for transfusion, and the antibody responsible for the reaction should be identified. The crossmatch incompatibility detected in antiglobulin crossmatch can be associated with the following conditions: presence of an alloantibody or alloantibodies to RBC-specific antigen on the donor unit, presence of passively acquired anti-A and anti-B antibody, presence of cold or warm reactive autoantibody, presence of antibody to an ingredient in the enhancement media or enhancement-dependent autoantibody, and the donor unit has a positive direct antiglobulin test. The goal of all the above procedures is to provide and be able to release appropriate, safe, and compatible blood for transfusion. In patients with a history of detectable clinically significant antibody or antibodies, they must receive units negative for the corresponding antigens. And in certain cases, it may be necessary to match the additional phenotype of the recipient to prevent further sensitization. Records review or check is also very essential. Current results must be compared with previous historical records. The history of clinically significant RBC antibodies should always be honored, even if the antibody is no longer present. Also check history of difficult compatibility or blood grouping, history of transfusion reactions, and history of special blood interventions or requests, such as the use of washed or irradiated units. Discrepancies must be resolved prior to transfusion. We have already discussed pre-transfusion testing. Now let us review the basic approach to a patient with difficult cross-matching. In our practice, we may encounter concerns regarding difficult cross-matching. These discrepancies in serological testing may occur for a variety of reasons. It may be categorized according to the lack of expected antigens or antibodies, or by the presence of unexpected antigen or antibodies. When we encounter such cases, we should work closely with the transfusion team in order to resolve these discrepancies. This is because unresolved serological antibody discrepancies can delay the identification of compatible units for transfusion or identification of an underlying abnormality. As part of the initial evaluation and management, communication between clinical team and transfusion team is crucial. Laboratory personnel must let the clinician know the complexity of the laboratory testing, the estimated time frame required to complete the testing, and what kind of patient history would be helpful to find possible causes of the incompatibility. Whereas the clinician must let the laboratory know the clinical urgency of transfusion, detailed pertinent history, and a treatment plan related to managing anemia and other concurrent medical problems. The best scenario occurs when the patient with an incompatible crossmatch is not in need of urgent transfusion. This allows for a complete immunohematologic evaluation and provision of compatible blood. However, for patients who are profoundly anemic and in urgent need of transfusion, a decision must be made based on an abbreviated laboratory evaluation. While this is being accomplished, the clinician can modify patient care such as providing supportive measures while waiting for the availability of compatible blood. The patient's medical history is very important and may provide clues to the cause of incompatibility. It is helpful to know the diagnosis of the patient because certain serological problems are more common with particular diseases. Second would be knowing the patient's medication history. For female patients, it is important to ask regarding their OB history, in particular history of pregnancy. And lastly, history of previous or recent blood transfusion. It is helpful to know the diagnosis for the patient because certain serological problems are more common with particular diseases. Warm autoantibodies are typically immunoglobulin G antibodies that may be primary or may be secondary to underlying disease states such as lymphoproliferative diseases or in collagen vascular diseases. Typical features of warm autoantibodies include a positive DAT, positive Rh control, and in most cases, a positive antibody screening result. Cold autoantibodies, which usually are immunoglobulin M type, are produced in primary or secondary cold hemagglutinin disease. Now, the biphasic IgG antibody found in paroxysmal cold hemoglobinuria or PCH is unlikely to be detected in routine serological testing because biphasic testing would be required as part of the investigation for an IgG that is associated with PCH. Other diagnoses are associated with abnormal plasma proteins that can cause artifactual agglutination or RULU formation. RULU is also observed in the laboratory when specimens are collected after infusion of certain intravenous fluids, such as high molecular weight dextran, and in medical situations in which plasma protein levels are elevated, such as multiple myeloma, inflammatory and connective tissue disorders, cancers, and pregnancy. It is important to get a comprehensive drug history in order to determine whether serological and clinical findings are consistent with drug-induced hemolytic anemia. Although it is not a complete list, the table presented here indicates many of the drugs that have caused a positive direct antiglobin test result and/or hemolysis. We have to know the patient's pregnancy history for females. This is because in the serum of a female patient with a history of previous pregnancy, IgG-RBC antibodies can be detected due to alloimmunization caused by fetal maternal bleeds. If the patient is currently pregnant, a number of serological problems can occur and should be considered, including passive anti-D, clinically insignificant cold agglutinins, and atypical agglutination. Cold agglutinins may be detected in the serum of a pregnant patient. These antibodies are not clinically significant. However, when detected, they generate additional investigative work for the laboratory. Two unusual or atypical patterns of agglutination can occur in serological testing in a pregnant patient. An increase in fibrinogen is a normal physiologic change during pregnancy and can result in RULU formation. Mixed field reactions have also been reported after a fetomaternal hemorrhage of a large volume of blood. The transfusion history is important because a history of previous transfusion may reveal a patient that has been alloimmunized to RBC antigens with formation of a potentially clinically relevant IgG antibody. If the patient has received a transfusion, it is important to know whether the transfusion occurred within the past 3 months, and if so, which blood product or products was or were administered. If the recent transfusion consisted of red blood cells, the patient could be having a delayed serological or delayed hemolytic transfusion reaction. If the recent transfusion was a plasma product, passive antibody might be the one causing the problem. If a patient has received a transfusion or has been pregnant within the past 3 months, the laboratory should perform phenotyping using a pre-transfusion specimen. This is because transfused donor cells may still be present in the circulatory system of the patient and cause erroneous results. However, if the transfusion history is remote, alloimmunization should be considered. Formation of an RBC alloantibody can occur in the days or weeks after transfusion. Typically, alloimmunization by this mechanism is clinically silent, and the alloantibody will only be detected during subsequent pre-transfusion testing. Given the time required to perform the appropriate testing, the severity of the patient's condition determines clinical management during the laboratory evaluation. In patients with active bleeding, whose blood loss outspaces serial hemoglobin measurements, clinical judgment must be used regarding the urgency of transfusion. The patient's ability to withstand severe anemia while awaiting transfusion can be maximized by enforced bed rest to decrease oxygen demand and the administration of supplemental oxygen to optimize dissolved oxygen in the plasma. For patients who require urgent or emergent transfusion, joint decision-making by the clinician and transfusion medicine physician should occur. Importantly, no patient should be denied a life-saving transfusion because of difficulties in finding compatible blood. For patients with urgent need for transfusion, blood can be issued under a non-standard release that is approved by a physician or as an emergency release. Patients with a confirmed ABO type can receive uncrossmatched type-specific blood, and patients without an available ABO type can receive type O blood. Type O negative red blood cells should be conserved in emergencies for female children and women of childbearing potential to prevent overuse of the limited supply of O negative red blood cell units. Emergency transfusion with incompatible blood may be necessary in patients with severe bleeding who have multiple alloantibodies to high-frequency antigens, autoantibodies, or ABO discrepancies. We urge that the best practice for attempting to transfuse these patients safely is to infuse blood slowly while carefully observing the patient for signs and symptoms of an acute hemolytic transfusion reaction. For instance, having chills, fever, respiratory distress, or pain in the chest or back during the transfusion. In the event of such signs and symptoms, the transfusion should be discontinued immediately. Now, if we are given the best scenario and the patient with an incompatible crossmatch is not in need of urgent transfusion, this will allow us for a complete immunohematologic evaluation and provision of compatible blood as mentioned earlier. Antibodies usually identified are alloantibodies and autoantibodies. The next slides will give us a brief overview and what to do in these scenarios. Finding compatible blood for patients with multiple RBC alloantibodies or antibodies against high-frequency antigens may be very time-consuming and is dependent upon the availability of blood lacking the corresponding antigens to which the patient has formed antibodies. There are three types of autoantibodies that may be responsible for causing incompatible crossmatches. We have the warm reactive autoantibodies, usually the IgG, cold reactive autoantibodies, usually the IgM, and drug-induced autoantibodies. Importantly, no patient with autoantibodies should be denied a life-saving transfusion because of difficulties in finding compatible blood for transfusion, because such patients are likely to tolerate serologically incompatible blood without significant complications. Warm autoimmune hemolytic anemia is the most prevalent form of IHA, accounting for 60 to 70% of all cases. It is caused by increased erythrocyte destruction by IgG autoantibodies with or without complement activation. The different pathogenic mechanisms, their complex interplay and changes over time may explain warm IHA's great clinical heterogeneity and unpredictable course. Moreover, warm IHA may be primary or associated with a variety of conditions such as lymphoproliferative neoplasms, autoimmune and infectious diseases, immunodeficiencies, solid tumors or transplants, or with drugs including the novel checkpoint inhibitors. Treatment pipeline for warm IHA include the following. It is well established that approximately 80 to 90% of warm IHA patients respond to glucocorticoids. Next in the treatment pipeline is rituximab. It may be used as first, initial therapy in combination with glucocorticoids. Second would be, it is an add-on to glucocorticoids if the hemoglobin does not improve with glucocorticoids alone. Third, a single agent for initial therapy. And fourth, a single agent for refractory disease. Now, folic acid administration is reasonable since chronic hemolysis can lead to folate deficiency due to increased folate requirements for compensatory red blood cell production. IVIG has limited efficacy as a single agent in IHA, but it is often helpful as an adjunct to other therapies. Other immunosuppressive and cytotoxic agents have been reported to be effective in IHA and can be used for individuals who do not have good response to glucocorticoids and rituximab. Now, for patients who relapse or are refractory to medical treatment, one have to consider splenectomy. Cold agglutinin disease is a form of autoimmune hemolytic anemia caused by cold-reacting autoantibodies. It usually affects the elderly. Now, hemolysis is more prominent the more the body is exposed to the cold. The antibody involved is usually IgM. Cold agglutinins may be seen with the primary cold agglutinin disease or secondary cold agglutinin syndrome. Primary cold agglutinin disease is used to refer to cold agglutinins that cause RBC agglutination and extravascular hemolysis in the absence of an underlying disorder. Now, when cold agglutinins arise in the setting of an underlying disorder, such as a viral infection, autoimmune disorders, or lymphoid malignancies, the syndrome is referred to as a secondary cold agglutinin syndrome. It should be noted that not all individuals with cold agglutinins have clinical manifestations. But for those who do, treatment is directed at, first, minimizing cold-induced symptoms, second is maintaining an acceptable hemoglobin level, and if required, 3, addressing underlying disorders. In drug-induced IHA, the anemia recovers when the implicated drug is discontinued and may recur if the same drug is re-administered. In summary, PreTransfusion testing includes a series of tests aiming to provide blood components that will provide maximum benefit while minimizing risk and potential harm to the patient. Before deciding to transfuse, always weigh benefits versus potential risks. In emergency situations, the benefits will clearly outweigh the potential risks. No patient should be denied a life-saving transfusion because of difficulties in finding compatible blood. Best practice is to infuse blood slowly while carefully observing for signs and symptoms of acute hemolytic transfusion reaction. And if present, stop the BT or the blood transfusion immediately. For those with an incompatible crossmatch not in need of urgent transfusion, completing immunohematologic evaluation will help identify compatible units and/or identify and eventually treat any underlying abnormality. For these cases, communication between the clinical team and the transfusion team is very essential to optimize patient care. I sincerely hope that you learned a lot from this lecture. Thank you very much for your kind attention. The following are the references used for this lecture. Have a nice day, everyone, and learn a lot from this postgraduate course. Thank you.